Hi everyone, I am Dr. Aditya. Today we'll be discussing the topic syncope. So, what's syncope? The definition itself tells you almost everything that you need to know about. It tells you what are the clinical manifestations, what is the pathophysiology, and what is the treatment. So, what's the definition? It's a transient loss of consciousness and postural tone from vasodepressor or cardiogenic causes. So you know what is the clinical manifestation? There's a loss of consciousness as well as postural tone. What is the pathophysiology behind it? It can be due to vasopressor or cardiogenic causes. Along with it, very important to have prompt recovery without any restrictive measures. Otherwise, we have mimics. We can go for we have an syncope mimics. We can have stroke. We can have seizures. What are the high risk features? Anyone having a structural heart disease, abnormal ECG findings, and age more than 60 years are risk factors for syncope. Note that specific factors or any cause is identified only in 50% of the individuals. Going behind this syncope with pathophysiology, there are mainly three. One is reflex neurologically mediated, second is orthostatic, third is cardiogenic. First, coming to reflex, it is due to excessive vagal tone or impaired reflex control of the peripheral circulation. Now we dive down into the details. The most common type is vasovagal. You might have heard it so many times in the wards that this patient is having vasovagal, that patient had a vasovagal. So this is initiated by stress, pain, or due to a claustrophobic sensation. Many a times we have patients with full bladder just fainting in front of you, or sometimes we have medical students fainting down in the dissection halls. That is all vasovagal mediated. Other can be less common. This is the most common type. Less commonly can be due to carotid sinus hypersensitivity. There can be post-micturition, seen mainly in the cardiac patients, or it can be vagal induced sinus bradycardia, sinus rest, or a AV block. We know that vagus has an inhibitory action on the cardiac pace generating cardiac pace generators. So it can cause sinus bradycardia, sinus arrest, and AV block, and that in turn causes syncope. Second, we have orthostatic or postural hypertension. It is a vasodepressor syncope seen mainly in the elderly, diabetic, and neuropathic. Also in patients with blood loss or hypovolemia, and with some drugs such as vasodilator, diuretics, and adrenergic drugs. Basically, there is loss of the vascular tone due to either volume loss, hypovolemia, drugs, or autonomic failure. The normal vasoconstrictive response to assuming upright posture is impaired. This causes an abrupt decrease in venous return, causing syncope. Third, it can be cardiogenic. Cardiogenic, it can be either mechanical or arrhythmogenic. Usually there is no prodrome in cardiac causes. They occur out of the blue. So there is high risk of injury. Orthostatic and reflexogenic, neurally mediated, we usually have a prodrome. The patient is able to tell that I'm going to fall, so he sits down or something. Mechanically, patient can aortic stenosis, outflow obstruction, pulmonary stenosis, hypertrophic cardiomyopathy, congenital with pulmonary hypertension, or a right to left shunt, or there can be a left atrial myxoma causing an obstructive ball valve mechanism. It can be arrhythmogenic. We can have a sick sinus, AV blocks, ventricular tachycardia, or supraventricular tachycardia with a fast ventricular rate. So from this, what do we understand about syncope? Syncope is a state of global hypoperfusion global hypoperfusion, that is transient. You see, all of these causes, these are all transient. Second, we come, what are the signs and symptoms? We can have a prodrome of vasodepressor premonitory symptoms such as nausea, diaphoresis, tachycardia, pallor. So many times the patient is able to tell. Mostly in the non-cardiac causes, the patient will be able to tell. Episodes can be aborted by, very important, you removing the stimulus. You are having pain, you remove the painful stimulus. You are having claustrophobic sensation, you go into a big room. Second, you are having a full bladder sensation, you void urine. Second is by lying down. You lie down flat on the ground, raise your feet, the cerebral perfusion increases. Second is cardiogenic. This is usually abrupt and there's nothing much we can do. In orthostatic hypotension, how do we define it? More than 20 mmHg of fall in blood pressure upon rising from supine to standing, with or without tachycardia. This is important depending on the status of the autonomic function. This is the baroreceptor function. When do we measure it? 3 minutes after standing. Has to be supine for 5 minutes. You have to be supine, then 3 minutes of standing. We measure it. Historically, in examination, it's important to ask for a history of orthostatic BP fall. You need to auscultate for the carotid arteries, because we have already seen one of the causes is baroreceptor hypersensitivity. It can be because of a concomitant carotid atherosclerosis or plaque. And cardiac examination is very important. There can be structural causes as well as rhythmic causes. Investigation, 3 main: ECG, autonomic testing, and EPS. ECG is a must-have in all patients. It is cheap, fast, non-invasive. A resting ECG is required, and in high-risk patients, we example, if we have a non-sinus rhythm or a left bundle branch block, complete or partial, or feature suggestive of a left ventricular hypertrophy, then we have to go for further workup. If the resting ECG is normal and there's possible cardiac arrhythmia suspected, we can go for an ambulatory ECG, an event pre-recorder, or an implantable cardiac monitor. This will give us the 24-hour or 12-hour ECG recordings. If the event that is occurring is transient, this can help us out. Second, we can go for autonomic testing. Gold standard for that is tilt table testing. We do it whenever we are suspecting a vasovagal syncope after ruling out other causes, and this is done especially if we are having recurrent autonomic kind of syncopes. It is important that while we are doing autonomic testing, we do hemodynamic monitoring for cardio inhibitory, vasodepressor, and mixed kind of responses that can occur at the time. Last is EPS, electrophysiological study. It is a limited role. It has a yield in structural heart diseases, ischemic heart disease, LV dysfunction, or any known cardiac conduction disease or arrhythmia. Treatment mainly is educate the patient that this is a benign disease, will not progress. We have to counsel regarding the predisposing conditions and tell the patient how to avoid it. Teach them about the counter pressure maneuvers such as squatting, leg crossing, lying down on the ground, abdominal contraction, but these have limited role in terminating. Medical therapy is reserved only for the patients who remain symptomatic despite adequate measures. These are limited efficacy to be noted. One is midodrine, it's an alpha agonist. Other of less benefit is fluhydrocortisone, beta blockers, and selective serotonin receptor inhibitors, reuptake inhibitors. There's no role of permanent pacing except in patients more than 40 with prolonged more than 3 seconds of symptomatic episodes of asystole documented, symptomatic bradycardia, and high degree AV blocks. This congenital heart blocks and morbid type 2 block. Important in all patients, you have to tell them there has to be driving restrictions. If this is a temporary factor for 1 week, the symptomatic VT or a aborted sudden cardiac death for at least 6 months, and if it's a persistent arrhythmia, we have to go for longer restriction. Thank you everyone. PDF of this document is there. You can mail me personally, and I'll forward you this document if you want it. My email is adsytube03@gmail.com, and I'll send you the PDF. Thank you.